Welcome to another short video on Pulsus Paradoxus. While checking arterial pulse, it is important to observe respiratory variation of pulse amplitude. Systolic arterial pressure normally falls during inspiration because of dropping the intrathoracic pressure, although the magnitude of decrease usually does not exceed 8 to 12 millimeters of mercury. These changes in pulse amplitude are not usually appreciated by palpation, but can be established with a sphygmomanometer. A more marked inspiratory decrease in arterial pressure exceeding 20 millimeters of mercury is termed Pulsus Paradoxus. In contrast to the normal situation, this is easily detectable by palpation, although it should be evaluated with a sphygmomanometer. When the cuff pressure is slowly released, the systolic pressure at expiration is first noted. With further slow deflation of the cuff, the systolic pressure during inspiration can also be detected. The difference between the pressures during expiration and inspiration is the magnitude of Pulsus Paradoxus. The inspiratory decrease in systolic pressure is accentuated during very deep inspiration or Valsalva. Thus, assessment of Pulsus Paradoxus should be made only during normal respiration. Etiology of Pulsus Paradoxus. Pulsus Paradoxus is an important physical finding in cardiac tamponade. In patients with suspected cardiac tamponade, electrocardiography should be performed to detect pericardial effusion and ventricular diastolic collapse. Echocardiography is more specific and sensitive than Pulsus Paradoxus for the diagnosis of tamponade. Pulsus Paradoxus may not occur despite cardiac tamponade in patients with hemodynamically significant aortic regurgitation and atrial septal defect. In addition to tamponade, Pulsus Paradoxus can occur in chronic obstructive pulmonary disease, hypovolemic shock, and infrequently in constrictive pericarditis and restrictive cardiomyopathy. It is rarely observed in pulmonary embolism, pregnancy, marked obesity, and partial obstruction of the superior vena cava. In hypertrophic obstructive cardiomyopathy, arterial pressure occasionally rises during inspiration, a reversed Pulsus Paradoxus. The precise mechanism for this phenomenon is, although unclear. In addition to changes in the amplitude, configurational changes of the carotid pulse may also occur. Mechanism of Pulsus Paradoxus. The mechanism for the marked inspiratory decrease in arterial pressure with Pulsus Paradoxus appears to be related to the inspiratory decline of left ventricular stroke volume due to an increase in right ventricular and diastolic volume and a decreased left ventricular and diastolic volume. In cardiac tamponade, the interventricular septum shifts towards the left ventricular cavity during inspiration, a reverse Bernheim phenomenon. This is a result of the normal increase in the venous return to the right side, thereby decreasing the left ventricular preload. An inspiratory decrease in pulmonary venous return to the left side of the heart also has been thought to contribute to the decreased left ventricular. It can be seen in cardiac tamponade, constrictive pericarditis, in certain non-pericardial diseases like restrictive cardiomyopathy and right ventricular myocardial infarction. Some of the important non-cardiac causes of Pulsus Paradoxus include asthma, chronic obstructive pulmonary disease, obstructive sleep apnea, pulmonary embolism, tension pneumothorax, bilateral pleural effusions, and in patients with marked obesity, hypovolemic shock, pectus excavatum, and extrinsic cardiac compression, Pulsus Paradoxus can also be seen. Here's a graph demonstrating the mechanism of Pulsus Paradoxus. The intracardiac pressure tracings from a patient who developed cardiac tamponade is described here. During inspiration, the pulmonary capillary wedge pressure drops below the left ventricular diastolic pressure, leading to underfilling of the left ventricle and an acute drop in the left ventricular stroke volume, causing Pulsus Paradoxus. Here's a graph demonstrating Pulsus alternans and Pulsus Paradoxus in terms of the arterial waveforms. In Pulsus alternans, which is associated with severe left ventricular systolic dysfunction, there is variation in the amplitude of the systolic arterial pressure with every other beat. In contrast, Pulsus Paradoxus varies with the respiratory cycle, such that the duration of the arterial pressure reduction is sustained during the inspiratory portion of the respiratory cycle. That concludes our video on Pulsus Paradoxus.